Thank you very much. Hello once again. And now management of Bechet syndrome. So while waiting for the slides, these are my disclosures. For management of Bechet syndrome, just similar to all other rheumatology conditions, there is no single management strategy that would fit all patients. So we try to individualize the treatment according to the age of the patient, the gender, types, and severity of organ involvement. And we keep in mind the risk factors that we talked about this morning. We know that males have a more severe disease course. We know that those developing the disease under the age of 25 have a higher risk of developing major organ involvement. And we know that these major organ involvements are more frequent during the early years of disease. And we know that major organ involvement should be treated aggressively from the beginning in order to prevent damage and even death. On the other hand, for skin, mucosa, and joint lesions, we individualize the treatment according to the patient's choices, patient's preferences. Well, a treat-to-target strategy is being developed for all rheumatologic conditions. I have to admit that as Bechet's experts, we have not been very successful in doing this. The lack of well-defined targets makes it difficult to develop a treat-to-target strategy for Bechet syndrome. We yet do not have definitions for remission or low disease activity. What we have is just some potential targets for specific types of involvement, and I will be talking about those in a minute. In 2018, we have updated the EULAR recommendations for the management of Bechet syndrome. What I will be doing in this talk will be to overgo some of the new data that were reported after these recommendations and suggest some of the things that should be changed in the future updates of these recommendations. So let's start with skin, mucosa, and joint involvement. Remember, we said almost all of the patients have these manifestations, and about 50% of the patients have only skin, mucosa, or joint involvement. In patients who have oral and genital ulcers, in the management of the new active ulcer, what we do is we use topical agents, and most frequently corticosteroids. Apart from that, lidocaine gel, sarcalphate suspensions, chlorhexidine have been used as topical treatment modalities. And if the patient is having only occasional oral or genital ulcers, these may actually be sufficient, and the patient may not have to receive continuous systemic treatment. But discussing this together with the patient, discussing how much these bother the patient, you may decide to give a systemic treatment. And the first-line systemic treatment is colchicine in majority of the patients. This is also true for erythromelalgia and for arthritis. For all of these conditions, colchicine works quite well in patients. And for papulopustular lesions, we would be using topical or systemic agents that are used in acne vulgaris. So going back to ulcers, erythromelalgia, and arthritis, if the patients are refractory to colchicine treatment, what we will be using is immunosuppressives. Of course, again, discussing with the patients and taking into consideration the potential risks. These could be azathioprine, interferon alpha, TNF-alpha inhibitors, and for oral and genital ulcers, thalidomide was shown to work very well. And recently, apremilast was shown to be effective for oral ulcers and maybe genital ulcers also. I think the most important change in this part of the recommendations would be apremilast, which in my opinion would be coming to right after colchicine prior to immunosuppressives, because it's not an immunosuppressive agent, it's an immunomodulatory agent. And it doesn't cause any infections, and it seems to be a bit safer than the other agents. This is the phase 3 trial of apremilast that was recently published. And as you can see here, there is a rapid decrease in both the number of oral ulcers and the pain of oral ulcers in the apremilast group compared to placebo. And also there's an important increase in improvement in overall disease activity and quality of life of patients with Bechet syndrome using apremilast. Another potential agent, I think, that has to be studied is ustekinumab. This is only the long-term extension of an open-label study, uncontrolled study of 30 patients who had at least 2 oral ulcers despite colchicine. And this is the French group who did this study. And they saw that with ustekinumab, 90 milligrams that was used at baseline, 4 weeks and 12 weeks thereafter, there was a complete remission rate of 60% and plus partial remission rate of 30% in these patients. So these results really look similar to apremilast. Of course, this is uncontrolled data. And another new agent is pentoxifillin gel. We presented this a few months ago in the ACR for the first time. This was a phase 2 study comparing pentoxifillin gel in addition to colchicine alone for for shortening the duration of oral ulcers. And we really saw that. We took photographs of the ulcers, starting from, these were new ulcers that appeared during the last 48 hours, and we took photographs every 24 to 48 hours to see how the lesions got smaller. And this was a very small phase 2 trial where 41 patients were randomized and 39 of these completed the study. 2 patients had to withdraw because the drug really tastes very bad. And we saw that topical pentoxifillin, in addition to colchicine, seems to accelerate the healing of Bechet syndrome oral ulcers. Both the duration and the pain of oral ulcers significantly decreased compared to placebo in these patients. But as I said, the drug is tasting really bad, and the company is now working on it for the phase 3 trial. And so this may be a potential agent, a potential topical agent for Bechet patients who have occasional ulcers. Going to the management of uveitis, as we talked in the morning, it's about 10 to 15% of the patients who have isolated anterior uveitis, and these have a low chance of having a drop in their visual acuity. So only topical corticosteroids during the acute anterior attacks may be sufficient for these patients. But if there are high-risk patients, namely male patients who have an early age at disease onset and early during their disease course, I think these patients do have to receive systemic immunosuppressives, deserve immunosuppressives. And what we usually start with is azathioprine in these patients. For patients who have posterior uveitis, right from the beginning, in addition to corticosteroids, the patients should be using immunosuppressives. These could be azathioprine with or without cyclosporine A. These could be interferon alpha, and these could be monoclonal TNF inhibitors. There's a wide variation between countries, between experts in the choice of these drugs, and there's really no data to show whether one is superior to the other. And in patients with acute sight-threatening uveitis, high-dose corticosteroids together with interferon alpha or TNF inhibitors should be started right from the beginning. As I said, we don't know. There are no head-to-head trials comparing interferon alpha to TNF inhibitors. And in the long term, the efficacy seems to be quite similar, looking at open-label studies. But we know that infliximab has a more rapid onset of action, and depending on the other organs that are involved, you may decide to use TNF inhibitors because it also works for gastrointestinal involvement, nervous system involvement that may accompany uveitis. And also the adverse events with interferon alpha, we know that flu-like symptoms and depression could be quite problematic. On the other hand, with TNF inhibitors, we may have infections, especially tuberculosis is a big problem in countries where Bechet syndrome is prevalent. So you should be screening those patients very well. And also cost and reimbursement policies may be effective in the choice between these two drugs. What do we know about the efficacy of TNF inhibitors in uveitis? This is, I think, the largest, not study, I would say. This is a post-marketing surveillance, but it's the largest report on TNF inhibitors in Bechet uveitis. In Japan, they reported on more than 650 patients who used infliximab with very good results in decreasing the number of attacks, the number of patients with attacks, and the visual acuity in patients. However, there were important adverse events. The serious adverse event rate was 6%, and 3.7% had serious infections among these patients. Which TNF inhibitor to choose? Well, infliximab and adalimumab are the most frequently used ones until now. We know that adalimumab was approved for uveitis a couple of years ago based on these 2 randomized controlled studies. In these studies, there were only very few patients with Bechet syndrome. However, what they did was they took these 27 patients, the total, in 2 randomized controlled trials, and they looked at the long-term results of these subgroup of Bechet syndrome patients. And as you see here, there was a good number of patients who had no active inflammation at week 87, that was 96%, and no active inflammation and complete quiescence, meaning the anterior cell grade was very low and the vitreous haze grade was very low, was 91% at week 78. And there was an important improvement in visual acuity in these patients. So adalimumab also seems to be a good option in patients with Bechet's uveitis. I think after this talk, there will be a session on biosimilars. Just a very short comment on biosimilar use in Bechet syndrome. We recently reported these patients, and biosimilar infliximab seems to work in patients with Bechet syndrome, just like original infliximab. One of the questions that is frequently asked, whether concomitant immunosuppressives should be used in patients with Bechet syndrome together with the TNF inhibitors. Well, data says that, this is also retrospective data, but it says that there is no additional benefit of concomitant immunosuppressants. However, I usually prefer to give my patients concomitant immunosuppressants because if for some reason they have to stop TNF inhibitors, even for a short while, because if they cannot get the medication or just get a flu and have to postpone it for a few weeks, they can rapidly develop relapses of uveitis. So I think this background azathioprine or cyclosporine, I have a feeling that it may be protecting them from these attacks, but this is really not evidence-based. And another question is, can we stop TNF inhibitors in these patients? Well, there are 2 studies that looked into these, 2 recent studies. One of them looked at 22 Bechet syndrome patients who were started infliximab for refractory uveitis, and after 2 years, when these patients were remission, TNF inhibitors was stopped. And we see that among about 2/3 of these patients, 14 of the 22 patients, after 3 years were still in remission, and 10 of them were without medication at the end of a mean period of 6.8 years. So if the patient is remission, it seems to be possible to stop the TNF inhibitors. The other one is with adalimumab, and in this study, 74 patients who were given adalimumab as first-line TNF inhibitor, after obtaining remission, their TNF inhibitors were tapered and stopped in 42 of the patients and continued in 36 of the patients. And the authors saw that there was a similar outcome regarding visual acuity, macular thickness, and steroid-sparing effects. So how do we stop TNF inhibitors in Bechet syndrome? I think these are really from retrospective data, but I think we can say that there should be at least 2 years after the last attack. We should be performing a fluorescein angiography and making sure that there is no capillary leakage. We should continue, or we should restart if we were not using a conventional immunosuppressive such as azathioprine or mycophenolate, and continue these for at least 5 years after the last attack. I think we should be first increasing the dose intervals or dropping the dose and stop gradually over at least 1 year. And even after that, we should be carefully following the patients with regular ophthalmologic examinations and, if necessary, fluorescent angiographies. So do we have a treatment target for uveitis? I think having no capillary leakage on fluorescein angiography is a good treatment target for Bechet's uveitis because we know that high fluorescein angiography scores are associated with relapses in these patients. And I think when monitoring our patients, this should be our aim, to have no capillary leakage. Going on to CNS involvement, well, in the morning we were discussing there are 2 types of CNS involvement. One of them is cerebral sinus thrombosis, which is actually a part of vascular involvement of Bechet syndrome. And in these patients, what we do is we give high-dose corticosteroids. In majority of the patients, there is only 1 attack. So some experts argue that we do not need immunosuppressives in these patients. Just suppress the thrombotic attack with high-dose corticosteroids, and that's enough. But some experts, including myself, think that immunosuppressives for at least 2 years, I would say, is necessary in these patients, at least because these may be associated with other vascular lesions. And I think immunosuppressives would have a protective effect in such patients. And for the use of anticoagulants, again, there's a lot of controversy, but there's really no data for or against anticoagulation in these patients. If the patients have recurrences despite immunosuppressives, then we could use monoclonal antibody TNF inhibitors here also. So for the majority of patients with CNS involvement, those that have acute parenchymal involvement, we start with high-dose corticosteroids, and this is really high-dose corticosteroids. What we do in our clinic is have 7 to 10 intravenous boluses of 1 gram methylprednisolone, followed by 1 milligram per kilogram of oral prednisolone. And we use immunosuppressants. We usually start with azathioprine unless this is a very severe and disabling involvement. In those patients, we use first-line monoclonal anti-TNF inhibitors. And even in the patients who were moderate to less severe, I would say, and we started with azathioprine, if they have a chronic progressive course or if they experience recurrences, we go on to monoclonal anti-TNF inhibitors. So we were discussing this morning with colleagues, with Dr. Hussam, I think, whether there was any data comparing cyclophosphamide to infliximab in patients with nervous system involvement. So I added this slide. There are actually only 2 retrospective studies on cyclophosphamide used in nervous system involvement. One is a Korean study which compared cyclophosphamide plus high-dose corticosteroids to high-dose corticosteroids only for Bechet syndrome nervous system involvement. And they showed that there was no difference between these 2 groups regarding suppression of the inflammatory attacks or preventing the relapses. And the other one is a retrospective study from the French vasculitis group, where they retrospectively compared their patients who used cyclophosphamide or azathioprine for nervous system involvement. And again, there was no difference between the 2 groups. The only difference was in the subgroup of patients who had a very high Rankin score, a baseline Rankin score more than 3. At the end of 3 years, there was a just slight difference between the 2 groups, and cyclophosphamide patients did better if they had a high baseline Rankin score in their disability score. For infliximab, there is also not very high-quality data. I think this is still the largest series of 16 patients with CNS involvement who were treated with infliximab. These patients had at least 2 CNS attacks before infliximab, and they had a mean duration of CNS involvement of 47 months. And they were started infliximab together with azathioprine and or prednisolone in 10 of them. And at the end of follow-up, there was improvement in 4 of the patients, and the disease was stable in the rest of the 12 patients. However, there were important adverse events. 1 patient had tuberculosis, and the other patient had recurrent catheter infection. Coming to the management of vascular involvement, for acute deep vein thrombosis, what we do is to give a short course of systemic corticosteroids, a moderate dose of systemic corticosteroids, and to start with immune suppressants right from the beginning. This could be azathioprine or cyclosporine A for venous thrombosis of the extremities, and it could be cyclophosphamide for thrombosis of vena cava superior or inferior, or hepatic vein thrombosis causing Budd-Chiari syndrome. The use of anticoagulants is really controversial. I will be talking about that in a minute. But if the patients do have recurrent deep vein thrombosis, then again the choice is between interferon alpha or monoclonal anti-TNFs. What we have is only open-label uncontrolled data. With interferon alpha, this is our recent work on prospectively followed patients with their first episode of deep vein thrombosis. We had 33 such patients that were recorded between 2010 and 2014. 29 of the patients were started azathioprine as first-line immunosuppressive. 2 received interferon alpha because they had concomitant uveitis, and 2 received cyclophosphamide because they also had large vessel involvement. And among these patients, among these 29 patients on azathioprine, 45%, so 13 of the patients experienced relapses. And these patients were switched to interferon alpha, And the cyclophosphamide patients also received interferon alpha for maintenance after 6 months, and there were the 2 patients who used for uveitis. So this total of 17 patients with interferon alpha were followed. And we saw that only 12 patients, 2% of the patients, experienced relapses under interferon alpha, compared to 45% in azathioprine. And when we looked at the recanalization rates, which is very important actually, it was again 45% with azathioprine, but it was 86% in interferon alpha. So this is not really a fair comparison because all of the patients had used, I mean, most of the patients had used azathioprine before coming to interferon alpha, and 3 of the patients already had good recanalization at interferon onset. But this is really the only data we have. And for TNF inhibitors, there's an Italian study that it's a retrospective study that compares adalimumab to conventional DMARDs for preventing relapses of deep vein thrombosis. And they saw that there were less relapses and more rapid and effective clinical improvement in patients with deep vein thrombosis in the adalimumab group compared to conventional DMARDs. And they also noted that anticoagulant use did not improve the response rates in either of the groups. So coming to anticoagulation, let's stop for a minute and think, why are we anticoagulating our patients with deep vein thrombosis? Not Bechet syndrome, any patient. So we want to prevent pulmonary emboli, but we know that pulmonary embolus is very rare in Bechet syndrome patients. We think that it doesn't really exist because the thrombus is a very sticky inflammatory thrombus to the venous walls. We want to provide recanalization. This really needs to be studied. I don't know in Bechet syndrome whether anticoagulation provides recanalization or not. We want to prevent recurrent venous thrombosis, but we know that this is not successful in patients with Bechet syndrome. I will show that in a minute. And we want to prevent post-thrombotic syndrome. Well, there are 2 studies in Bechet syndrome, and these have conflicting results whether anticoagulation is preventing post-thrombotic syndrome or not. So for the relapse risk, we have done this meta-analysis for the EULAR recommendations, but this is a meta-analysis of the retrospective studies that reported on patients who did and who did not use anticoagulants and compared the relapse risks. As you see here, and there were some patients who did not use immunosuppressives, they used only anticoagulants. And this meta-analysis showed that immunosuppressives does not seem to decrease the relapse risk for deep vein thrombosis. On the other hand, anticoagulation does not decrease the relapse risk. Well, if you decide to anticoagulate for whatever reason, if there are recurrences or if you want to anticoagulate your patients with Bechet syndrome, it's very important to be cautious and initially screen these patients for arterial aneurysms, because as we talked about this in the morning, aneurysm bleeding can be lethal in patients, especially under anticoagulation. And we know that bleeding risk during anticoagulation in Bechet syndrome was around 3% in these retrospective studies. And we know that there is a co-occurrence of arterial aneurysms together with deep vein thrombosis in 81% of the patients with arterial aneurysms. Also with vena cava thrombosis and intracardiac thrombosis, there is an association. So there is a risk of developing arterial aneurysms in these patients with thrombosis during the course of their disease, even if they did not have it at the time you started anticoagulation. So I think great caution is needed here. So what could be a treatment target for venous thrombosis? Well, recanalization seems to be the best predictor of venous relapses. This is what our prospective small study on deep vein thrombosis showed. And we know that relapses result in post-thrombotic syndrome, these venous ulcers that are very, very difficult to heal. So I think we should be aiming at recanalization in our Bechet syndrome patients with deep vein thrombosis. For the management of arterial involvement for both pulmonary arteries and peripheral arteries, what we do is we start with high-dose corticosteroids, usually 3 pulses, followed by 1 milligram per kilogram oral prednisolone, together with 6 pulses of monthly cyclophosphamide. Why we do this? Because we know that the mortality rate is very high. It was 50% in the early years when patients were not properly treated. It is still 8% despite all the medications we have. We should be treating them very aggressively from the beginning. Patients with peripheral artery aneurysms, especially if they are larger ones, especially if they are bigger than 5 centimeters in diameter, would need surgery or an endovascular intervention may work in some of these patients. And if these patients are refractory, we go on to monoclonal antibody TNF inhibitors. So also, like in other vasculitis, we are trying to get away from cyclophosphamide in our patients. And there's some discussion whether monoclonal anti-TNFs can be used as first line instead of cyclophosphamide in these patients. What we did was we looked retrospectively at our patients who use cyclophosphamide since the beginning of our clinic for 40 years. And we had a total of 198 patients. And we saw that 9% of the patients had short-term adverse events that required hospitalization or treatment cessation. These were hemorrhagic cystitis, infections, or cytopenias. And also some patients had long-term adverse events. There were 17 malignancies in 15 patients during 3,250 person-years of follow-up. And we also saw that 30% of our male patients experienced infertility after using cyclophosphamide. So TNF inhibitors could be a choice in these patients. There are reports, there are case reports and case series coming up that shows its efficacy. But still, in my practice, if a patient has life-threatening vascular involvement, we start with cyclophosphamide in these patients until there is more reliable data. For gastrointestinal involvement, the treatment is very similar to Crohn's disease. In the morning, we were discussing how the endoscopic lesions, how the clinical findings may be very similar. The treatment is also similar. In patients with mild to moderate gastrointestinal involvement, we usually start with systemic corticosteroids and 5-ASA preparations. For patients who have severe exacerbations, we usually start with azathioprine. And in those, we started with 5-ASA and were refractory or showed recurrences, we can go on to azathioprine. And in all refractory and recurrent patients under azathioprine, we would be using monoclonal anti-TNFs. If the patient has a perforation, obstruction, or major bleeding, which occurs in about one-third of the patients, then there will be emergency surgery, of course. But it is very important to give these patients the surgery with good immune suppressions. You have to give high-dose corticosteroids and immune suppressants in order to prevent the perioperative complications. This is also true for patients with peripheral artery aneurysms that need to be operated. With TNF inhibitors in gastrointestinal involvement, there are only open-label case series, and this is one of the most recent and largest ones. They compared their patients who used only corticosteroids to those patients who used TNF inhibitors, and within TNF inhibitors, they compared those who used it concomitantly with corticosteroids or TNF inhibitors alone. There were 49 patients in the TNF inhibitor group and 22 patients in the prednisolone-only group. And as you see here, the remission rates, the cure rates, were only 13% in the patients who used prednisolone alone. And remember, these patients also had concomitant 5-ASA. One of them was receiving azathioprine, one of them methotrexate. So there were also other conventional immunosuppressives in these groups. In this group, the cure rate was only 13%. On the other hand, in the TNF inhibitor group, when the TNF inhibitor group was given together with corticosteroid, the cure rate was 60%, and in the TNF inhibitor-only group, it was 45%. And what should be the treatment target for gastrointestinal involvement? We recently showed that fecal calprotectin is a good agent for determining disease activity. It had a sensitivity of 91% and specificity of 74%. And we also showed in the study that a normal fecal calprotectin level is the best predictor of endoscopic remission in patients with Bechet syndrome. So I think even if the patient is asymptomatic, we know that they can have ulcers. And a good strategy would be to monitor these patients with fecal calprotectin levels. And if the fecal calprotectin level starts to get high, we should perform endocolonoscopies to see if they have recurrences in their ulcers. In conclusion, the management of Bechet syndrome has to be planned according to the organs that are involved, disease activity, and severity with a multidisciplinary approach. Skin and mucosa is an important cause of impairment in quality of life of the patients, and the treatment should be really planned with patients according to patients' preferences, discussing with the patient. And here, apremilast is a safe and effective new modality. And for major organ involvement, the initial effective treatment is very important to prevent irreversible damage and even death in these patients. And biologics play an increasing role in such patients at high risk. Thank you very much.